purpose of this presentation is to look at a specific aspect of a super PCP model that's in development right now that allows the combination of independent and adult pediatric primary care to work together outside their ACO within federal agency guidelines. Want to make sure that we understand this is not legal advice. This presentation is not intended, it's just intended to convey general information only and not to provide legal advice or opinions. It is to stimulate discussion, to gather opinions from all that may have some expertise in evaluating the possibility of integrating a combination of both adult and pediatric primary care physicians that would satisfy current federal agency policy. So the contents of this presentation, the posting and the viewing of this information should not be construed, like I said, or relied upon for legal advice in any particular circumstance or fact or situation, and no action should be taken in reliance on this information contained in this presentation. A licensed attorney should be contacted for any advice on specific legal issues. The focus here is on the most valuable treasure for healthcare reform, and that's independent primary care providers. Everybody is starting to realize this. There are two federal agencies that are charged with making sure that physicians work within the law outside of their own practices. That's the FTC and the DOJ. They've issued these joint guidelines on these type of arrangements, which are concerned for antitrust scrutiny. Any physician joint venture is potentially considered an antitrust issue, and as such, people need to understand, especially physicians when they're practicing, how to avoid getting into issues that could create an antitrust concern. The focus, of course, is on primary care now, and then risk being forced in MSSP, which is causing many of the primary care physicians looking at leaving the MSSP program. Primary care contracting outside of an ACO participating in MSSP creates many significant legal issues that can infringe on federal guidelines, so everybody needs to be aware of these. We want to stay off the radar of the FTC. Two quick definitions you have to understand. One is per se illegal. This is defined by Section 1 of the Sherman Act. It's illegal even if it doesn't cause harm. So if two gas stations or two medical clinics agree on a minimum price, that is per se illegal. It doesn't matter if they show that there are many other competing gas stations or medical clinics and it did not cause the consumer any harm, it is per se illegal. So they are considered anti-competitive. There is no examination to see whether or not they did do harm or not. It's just illegal from the beginning. Rule of reason, on the other hand, is this allows for some agreement on price among competitors. It escapes this automatic or per se liability, but it still must survive the scrutiny under a test of reasonableness. For this analysis, you have to show that the pro-competitive impact outweighs the anti-competitive impact for this venture to be legal. What we're going to talk about here is two different things: clinically integrated networks, which group independent physicians to come together to identify and improve quality and offering care that, and they jointly contract mostly with commercial payers. Accountable care organizations or physicians, hospitals, other healthcare providers join together to provide improved care to Medicare patients, and then they move usually into commercial. Both groups are subject to the rule of reason. ACOs, because of their CMS participation, are given presumed rule of reason treatment because of their participation with CMS and the oversight, and the FTC has given this guidance and published it. CINs are not presumed to satisfy rule of reason because they're not in the CMS program, so they must be able to prove rule of reason. Any combination of competitors of physician network and physician networks run the risk of violating antitrust laws. It's two or more. The big CIN application of rule of reason came from Norman, Oklahoma, where they did the joint price negotiations between competing healthcare providers. From this, they determined that providers must be either financially integrated or clinically integrated, and the agreement, even if you're clinically integrated and financially integrated, the agreement still must be reasonably necessary to accomplish the pro-competitive benefits of the integration. So just saying you're clinically integrated doesn't stop, the analysis just not stop there. The first thing they do when they look at clinical integration is it doing anything to decrease competition, accessing the network's market power? So again, you can be clinically integrated, you can do whatever, but if you are inhibiting competition anyway, you fail rule of reason and thus are violating antitrust. And then you focus on the potential of offsetting efficiencies. Do you provide a net benefit of quality on a cost-adjusted basis? it's become difficult to justify what determines quality. You know, many of the quality indicators we do are just check marks and things like that, but that's something that's in evolution right now and still being determined. ACO versus CIN. Per the FTC, an ACO is similar to a CIN, but a CIN is not necessarily an ACO because the CIN focuses on commercial payers, ACO's initial focus is on Medicare. CIN doesn't have to expand to Medicare, and all providers can be members of multiple CINs, specialists can be members of multiple ACOs, but Medicare dictates that primary care can only be a member of one CMS program. One of the biggest problem networks are getting into right now is they're signing up too many providers. The more providers you get, the better, the more market power you have. This is where you get into trouble. If you're less than 30% in a particular specialty, including primary care, they consider this probably will satisfy rule of reason. If you exceed 50% in a specialty, that's where you start to get into trouble. It's not illegal. You can still prove it. But when you get way above 50%, then you get into the conditions where it's pretty much considered antitrust. So they've had networks that have had more than 50% that have passed rule of reason treatment, but then they've had those that have failed. It's specific to the market. For example, if you only have one group of neurosurgeons, it's going to be hard not to have 100% of them in your network in that area versus having, 65% of the TINs that are one specialty cardiology or primary care in that network. There's a big difference there. The critical thing to understand too is there's no absolute criteria for clinical integration. There's checklists, there's all sorts of things, and I'll show you in a second here what they do for that. But you have to, once you prove clinical integration, that does not protect you from FTC discipline. In the end, you still have to prove this rule of reason, why you had to join together to do this, and you did not inhibit competition in doing so. URAC is now clinically integrating, certifying clinical integration. It has all these different things, many of which a lot of times are just, checking a box, crossing a T, dotting an I, and costing a lot of money, and they may not be cost effective. The URAC is now credentialing adult and pediatric ACOs or CINs, so they have separated out a difference. And that'll come up here at the end here because I think that's an important point. So clinical integration is the process or the way to align, and ACO is the structure specific usually for Medicare. People think savings justify rule of reason. That can be illusionary. Savings that arise from curbing the incentive overutilization or over-provision of services could be evidence of an ACO's pro-competitive benefits. Savings that arise under provision of services that generate shared savings that will not improve the quality of care and thus should not be counted by the antitrust authorities because they resulted, like I say, from withholding care that could have benefited patients. So again, it's not an absolute it doesn't absolutely satisfy rule of reason. So they may not accept just saying that you generated savings as a fact that you provided value or that you proved rule of reason. Just because you're clinically integrated as part of an ACO or CIN doesn't mean you can take a subgroup of those same providers, move it out, and be clinically integrated under that. You have to start all over. Once you change the makeup of your ACO or CIN, you're considered non-integrated, and you have to prove that you're clinical integration. Spillover, huge issue. This is where we're getting into the problems now with people being part of multiple CINs, having ownership in competing ACOs. There's concern that this information, and this is called spillover, prices or negotiating strategies can be shared between or among competitors. So the whole purpose of clinical integration is the joint negotiation of fees, and that only moves the aspects from per se illegal, saying, hey, in the past, if you guys negotiated rates as a group, it was illegal. Now it's saying, okay, if you're clinically integrated and negotiated, it's not illegal, but you have to prove that it's not illegal. So again, just because you're clinically integrated, you don't get immunity from this. There is the dominant market share provider. Again, if you have 50% of a provider, of a specific type of provider in a service area, and that's defined by 75% of the zip codes you serve, that can be considered exclusive and thus anti-competitive. And now that this is especially true when you do an exclusive contract, we have over 50%, which is it's a requirement by the FTC to be non-exclusive. But when you do an exclusive contract, they're looking at that now and considering that possibly as exclusivity, and that would make this anti-competitive. High market share, when they first put these rules out, they said if you were over 50%, you had to come to the FTC for approval. They weren't giving you a choice. But then they felt that was going to be too regulatory, so now they've had some leeway there, but you still, once you go over that 50% threshold, you still have to prove rule of reason. So remember, the first step is on competition. There's a lot of groups, talk to groups around the country that think that they absolutely satisfy rule of reason just by claiming they're good for the community. They're using economics of scale, or the big one is adding value. That is absolutely not correct. Relative arguments is not, these arguments are relative and not absolute proof. So you can claim that you're good for the community, you can claim provide value, but if you're doing anything that inhibits competition, you can't say that you're not inhibiting somebody that could do that better than you, and that's the critical thing. So yes, it's important that you claim value, that you claim that you're good for the community, things like that, but you still have to not be able to inhibit competition. So if you look at the good community argument, basically that's the job of the FTC. So I think that argument doesn't hold any weight. The FTC determines if you're good for the community. You can't determine if you're good for the community objectively. They're the ones that have to determine that. Remember, absolute versus relative. An absolute claim would be just because we provided value to consumers, we're clinically integrated and prove rule of reason. The relative claims would say, hey, we provided value and we did not impede competition or make it exclusive. So the rule of reason almost always uses a relative impact, not absolute. So again, just saying you provided value doesn't satisfy rule of reason. Economics of scale, that's not usually a good argument either. It's similar to a merger. It creates market power. It could decrease competition. It gives a financial benefit to some at the expense of consumers. And the big question is, can these entities perform similar or better as separate entities? Value, like I said, it by itself is not a claim. It can create market power if you get too many providers in an exclusive arrangement, or you kind of inhibit competition by tying up certain specialties. So value is an important part of clinical integration, but it's not, it does not prove rule of reason or make what you're doing not subject to federal agency intervention. I've said this before, and I'll say it again, the future of primary care isn't what it used to be, just as the past was not what it's become. 3 years ago, I really focused on the fact that independent primary care was going to be the essential part of healthcare reform, and I started this super PCP CIN light model. I frequently gathered information from around the country, consulted, and sent some questions to the FTC to try and develop a model that's going to allow independent primary care to work as a network outside of their ACO or CIN and satisfy federal agency policy. The goal in this super PC was to include all primary care providers: internal medicine, family medicine, pediatrics, internal medicine, pediatrics. However, as I continued my quest to do this and got input, it was clear that I was not going to be able to satisfy the rule of reason, nor could anyone other expert in this field satisfy rule of reason to allow large groups of independent primary care clinics to work with large groups of adult primary care clinics. So that's the purpose of this today. I'm looking for people to come up with some other ideas that we may have missed that could argue that we can combine these two, because to date, it's pretty much unanimous. Nobody's been able to come up with a good rule of reason. And remember, there's some issues here. Pediatrics makes up less 24% of the population, but only 8 to 10% of the cost. So the majority of the cost is on the adults, and that's where it seems to be most of the focus. I'm not saying that's fair, but that's where it is. But also look at the way premiums are determined. This is critical in the future of value-based medicine and how we put these models together, because it's the total medical loss ratio, which is the amount of the premium that the insurers collect that's spent on medical care, that determines their profitability and how well they do. And it's age dependent. In adults, we see the average cost here is about $2,500 in the 1925, but over almost $9,000 in the 55 to 64. Well, look at the pediatrics. The average cost is $2,244. Here in this, this is a breakdown from insurance premiums. But when we look at the average cost, it's very much age dependent. 0 to 3, $412. So almost twice as much as any other categories in the 0 to 3, and then the 14 to 18 picks up again. But look at this 4 to 13. There's fairly minimal cost. And I'm going to show you in a minute why this makes is a big deal. I went out to our local Blue Value here, and I ran 58-year-old policy, single policy, $7,900 deductible, $617 was the cost for one person. So this is very much age dependent based on that 58-year-old versus when I left that 58-year-old to marry and added a 44-year-old, the cost only went up $300 for that, $350 for that 44-year-old as opposed to $617 we started with. But now let's look at how the insurance companies determine children's prices. Remember, I said 0 to 3 is almost twice of what everything else is. Well, when I add a 1-year-old child, it goes up approximately just less than $200. However, if I added a 10-year-old child or a 12-year-old child, which is the least expensive, it still went up about $200. So the price of premiums here is not age dependent for pediatrics. It's based on number. And again, remember, we said the 412. So there's a huge difference here. So with adults, they're collecting the premiums based on what they think the expenses is. On kids, it's just the number of kids, 1, 2, 3, or 4. And this is where it gets very interesting because, like I say, I add an 8-year-old child, it goes up another $200 from the 1176. I add a third child, it goes up to 1564. So now we paid about $600 for 3 children. Well, look what happens after 3 children. I can add 1 child or I can have 8 children in this family. The price doesn't change after 3 children. So therefore, a lot of, when you're looking at these value-based and shared savings type things, you're going to see there's a lot of variables here that depend on what types of families, family size that you have, the age of those families, and maybe some increased illness burden. Is only less than 10% of the pediatric population has an acute illness that requires treatment. So, and we look, the spending goes up dramatically as we go from 19 up to 65. But the critical thing here that is the problem the FTC is having to focus on is less than about, these deductibles, we said that deductible was $7,900. These deductibles are not being reached, but maybe by a small percentage of patients. Therefore, the cost to see you as a primary care doctor or as a specialist or whatever is eaten by the patient. The patients usually have to pay that. So if these fees go up and they go up high enough that are above market rates, it's not hurting the insurers as much, but it is hurting the patients, and that's where the FTC is concerned. So the payers are no longer the whistleblowers to encourage a network of peds and adults. They need peds for marketing and enrolling patients. So it was very interesting when I was talking to these payers. That's like, oh yeah, you can sign up as many as you want, and we'll combine it. And as I got into this, I realized more and more when I looked at the numbers why that was the case, because they want marketability, and the pediatric expense is more easily predicted. That's why they're charging that flat fee. But the expense is only less than 10% of their total medical costs. So 90% of everything goes to the adult, and that's where they can buffer the pediatric expenses. So the feedback I've gotten from the commercial payers seems to be Medicaid is the model for a pediatric ACO, and the cost savings, this would be good with a statewide pediatric ACO that was hospital-centric, children's hospital-centric. Almost all the payers are agreeing that the value-based or shared risk models for pediatrics is relatively non-existent at this point, and it's independent of adult lives. That's why they haven't set it up specifically. This case by Dr. Mark McClellan here from Duke further exemplified that almost all the models being set up are set up for adults. They're not set up for kids. So to clinically integrate pediatrics and adult, we've got to ask ourselves some questions. Can we even do this? Are evidence-based treatment protocols similar? No, I would say they're not. Is there crossover in illness burden and diseases? Probably not. Is there common ground on prescribing medication, use of lab specialists, radiology, rehab? All of this equal benefit in each individual group? No, there's a big disparity probably there. Is there crossover in case management? No, again, a lot more socioeconomic things with the kids and again, pretty much a separate support system. And is there crossover in high-value specialists? Absolutely not. We got pediatric specialists versus adult specialists. So it seems like everything is segregated clinically, but for the sake of this conversation, I'm going to say that you could make an argument for clinical integration, even though it's difficult. But now that the URAC, which is credentialing CINs, is credentialing pediatric ACOs and adult ACOs as separate entities, it kind of makes the case that these should be separate. So the question is, if we can clinically integrate it, how do we prove rule of reason? Again, remembering most peds visits are well acute self-limited illness. They see their patients on average more than the adult. Specialists are almost 3 to 4 times as much in the adults as kids. There's if you combine a bunch of pediatric groups in the same market, you're not going to see that great of a difference in the PMPM cost as opposed to the adults where the illness burden is completely different. You're also not going to see the risk scores very much between those. And of course, the fees for pediatric care for primary care is going to be a much larger percent of the actual total medical costs for pediatricians than it is for adults. If you give the peds a 20% bump in fee for service, you increase the pediatric medical care cost by 10%, whereas with the adults, it's less than 1%. So there are a lot of issues that have to be considered here if we allow this to happen. Now, you can make an argument that rule of reason with a hospital ACO is different, because now you're vertically integrating outpatient and inpatient care. You're coordinating care, and that's the premise of a CIN. Usually the hospitals employ pediatric specialists as well. So again, you're clinically integrating not only inpatient and outpatient care, but you still have to prove rule of reason. The rule of reasons for peds versus adult, is there a pro-competitive impact of these groups working together versus working separately? These are the questions we have to answer. So to say yes, you have to prove that the adults peds combined ACO will have superior results for both treatment group compared to the peds specific ACO and the adult ACO. So basically what I've got to say is, if we combine them, is it going to be better than if we kept them separate? Is there an anti-competitive impact of them working together versus separate? Yes, potentially. Whomever has more pediatrics in their market does have more marketability and thus more attractive for the payers. So there is some anti-competitive issues here. Is there a whoops, I'm sorry, for some reason this repeated. I'm sorry. Is there a pro-competitive impact of the groups working together versus working separate? Like I said, Peds ACOs seem to be more efficient compared to the combined pediatric adult ACOs that we're going to see some data here in a couple minutes. And that's what I found when I really went into this, and I didn't realize they actually existed until I looked, and they're actually in many major cities. Is there an anti-competitive impact of them working together? Like I say, yes. Because basically, if you're looking at an adult-only ACO that has 40% adult primary care versus a group that has adults primary care with 40% pediatricians, well, because of ease of simplicity, the payers are going to want to work with that 40-40 group, and they may not be any better than just having the 40% of the adults. So there's a lot of things that you have to look at here that just are very difficult to prove. So like I say, even proving that we can clinically integrate them is different. It's even more difficult if we add large groups of that, because let's look at this. These are the questions you have to answer. How does adding a large groups of pediatricians improve the care of 64-year-old adult patient with CHF-DM AFib peripheral neuropathy? How does adding large groups of internists aid in the pediatrician in treating newborn complications or the treatment of 0-3? They don't. The clinical things seem to be separate. So I think making that rule of reason argument is why it's been so difficult to find anybody that can give us a decent one to make. You can, however, have pediatric patients in an adult-only ACO or pediatric ACO, because you can't exclude, like family practice, family medicine practitioners that see a lot of pediatrics or med peds just on the basis of their specialty in seeing pediatrics, because if you did that, you'd exclude them from being part of any ACO or CIN, and that would be anti-rule of reason. I mean, you'd basically be doing a disservice to these patients that have those providers as their, or pick those providers, because they can't benefit from being part of the ACO or CIN. So absolutely, you can have small groups of pediatrics or adult med peds or family medicine with pediatrics in an ACO and still satisfy rule of reason. So following these suggestions, can we have peds and adults in the same CIN and prove rule of reason? And the issue becomes deriving market power. That's where it seems to be, that's where it seems to break down, or else there wouldn't be an issue here. So exclusivity of the network is definitely, if you're greater than 30%, like I say, that you usually need to be non-exclusive. You have to be very concerned now with these newer exclusive contracts. That's what's creating this whole issue, because those are considered, they take you from non-exclusive to exclusive. If you have an exclusive contract and you're inhibiting others from joining, essentially, even though your ACO may be non-exclusive, you have to look at this arrangement as being exclusive, because this is how we're inhibiting competition. These are all at least just some of the pediatric ACOs that exist out there. There's a number of them. They're all doing a lot of things very similar. The Seattle one, the one I talked to recently here, they've increased their covered lives from 50 to 100,000. They're working together throughout the state. These are some comments I got from them that actually help justify why probably a pediatric ACO is better than an adult pediatric ACO, because they have completely different priorities. The most significant difference is the baseline health of the population they serve. Healthy patients present a challenge for providers because there's less room for improvement. Children tend to be predominantly healthy. Only 8% have a chronic disease. So their cost of care like I say, tends to be a lot lower. We saw $2,200 versus $5,000–$6,000. Working with the pediatric populations offers providers a different, unique opportunity to shift focus from healthcare to health given. Most children are healthy and require mostly preventive and wellness care. Pediatric ACOs have an opportunity to invest in strategies to make a significant difference in the quality of care for children at a fraction of the cost of caring for adults. When caring for children, wellness and prevention programs that hinge on immunization, nutrition, physical activity, and child care have become vitally important. So you can see from what the adult ACOs tend to do, these strategies by the pediatric ACOs tend to be completely different. The data sets, the IT things are different too. The storing in a data warehouse and coming up with these care management pathways are completely different than we have in adults. So the demographics of children and youth are more diverse than any other age group. They have higher rates of poverty, of course. That's why this is more centered around Medicaid, where it seems to have the biggest impact. So the opportunity for Peds ACO is preventing long-term consequences, but it doesn't really show a short-term return. So that's why it's going to be very hard to measure the quality of pediatric intervention in the short term. It's more of a long-term thing. So I wanted to just share you this one ACO, because this is similar to some of the other ACOs. This was the Pediatric Partners for Kids study. They improved the value of pediatric healthcare over time through cost containment while maintaining the quality of care. Again, they showed decrease in inpatient admission, increased inpatient bed days, emergency room visits, all of this centered around their intervention specific for pediatric patients. As I've done this, we've gotten feedback from other providers and networks. So the questions they've all had is, should pediatric and adult be under the same value contract when one controls 90% of the total medical cost and the other only 10%? Is there any overlap in these value-based outcomes? Because we have different quality endpoints and very limited intervention points. Does allowing Peds to be part of a CIN with signal signature authority give them a competitive advantage over the other pediatricians that are not part of this in the same community? These are all questions, like I say, that we gathered when we talked to others, and why would he even consider putting these two together in a CIN? Again, the big thing is when you break down trying to prove who's more cost effective between pediatric groups, you find a huge error in our current technology, because the risk scores for these groups between pediatric practices is very minimal, with the deviation. So it's not exactly who's taking, and because, like I say, the premiums are pretty much equal, it may not be who actually provides the best care or the most quality. It may be who has the most 4 to 12-year-olds that are healthy or not seeing a physician as much, that actually shows the better results. So again, there's a lot of difficulties when we try to equate what we do in adult ACOs with pediatric ACOs. In the adults, we have much greater variation in the risk scores. We have much greater variations in the cost because of these risk scores. So that's where, trying to incentivize and reward people for making decisions probably has a greater impact. So, when you put them all in one, it's hard to justify that the decision making and all the things that go into savings are equal. So this, again, some other questions. This one I got from another ACO here that's basically came out and told me, they said, well, don't you think Peds just joining ACO is just riding the coattails of adults at consumers' expense with all these deductibles and things like that? And again, that's a good question. Another one said, well, there's 820 ACOs and CINs. Why are there not more CINs combining adults and Peds? Almost everyone is adult-centric. And why are these private equity firms in the primary care space avoiding Peds? And I'm going to show you in a minute an example of that. It's clear that the premiums are not age-dependent. So now, when you combine these two, you become an actuary. You actually have to take risk. Now, if you have a bunch of patients pediatric patients that are assigned to you that have big families, more than 5 or 6 patients, or have a higher illness burden, or if there's a higher number of newborns or young 0 to 3s. So there are a lot of variables here that make combining these two different. And so I have completely changed my approach from day one, when I was adamant about putting pediatrics and adults in the same bucket. But I've seen pretty much that it doesn't seem to make sense. But again, I'm open to hearing if somebody else, because we've asked everybody for opinion, if somebody else can give us good reasons why we should do that. This is the question, the concern. I said Aledade just announced that they're going to work with Blue Cross, with hundreds of independently owned and operated primary care physician clinics across North Carolina. They're going to do this through an ACO model, but look at what they did. They excluded pediatrics too. They said it's only for the commercially insured patients for Blue Cross and Blue Shield, but only primary care practices that are internal medicine, family medicine, or general practice. Well, Dr. Patrick Conway is a pediatrician, and he's an outstanding person. He is a visionary that I think is going to revolutionize how primary care is valued. And this is, his network. And so I think this shows that at some point we've got to come up. My goal has been for the past year now is to try and start here in North Carolina a pediatric ACO that centers around these children's hospitals, gets the payers behind it, because I think we need that. I think we need the pediatricians to work together. And again, I think they from what I'm seeing, at least everything that's been proven to me, they need to work separately. That's the way we're going to improve the care for the pediatrics. But again, I'm trying to gather information because I'm going to get I want to get some final guidance on this. And so I presented the data that makes, kind of contradicted that peds and adults should be together, but I'm looking for people to contradict what I'm saying. I'm basically presenting one side of the argument. If you can come up with a side of the argument that argues why these two should be together, that's what I'm looking for, because to date, I haven't been able to get an answer or get anything that I can put in front of the FTC or others that kind of satisfies that rule of reason. So if you have any comments that contradict the material in this presentation or help prove rule of reason, please put them on this on the YouTube site here under comments, so I can get in touch with you. And if you have any specific questions, please don't hesitate to use that as well for a way to get in touch with me.